Good afternoon, colleagues. Thank you, CSI Heart Failure Council, for giving me this opportunity. Uh, we all know the ischemic patient with heart failure, the one who comes with severe dyspnea, overwhelming fatigue, and a low ejection fraction on echo. We have already optimized their GDMT, but they are drowning in their symptoms. The core question for us today as interventionalists is, can we offer them something more? Today I want to talk about a strategic, evidence-based approach to PCI that can be a crucial missing piece in their care. So before we talk about revascularization, let's acknowledge the incredible revolution we have seen in the medical management of heart failure. GDMT has transformed the prognosis, reducing the mortality and hospitalizations. We now have a multitude of therapies that have changed the trajectory of this disease. This is the bedrock of our practice. Our role is not to replace this, but to ask, what does a procedural intervention fit into this paradigm? So for years, we've looked to major trials for our thinking on this. The primarily of them being the STITCH trial, which compared CABG to GDMT alone, and more recently, the revived BCIS2 trial, which compared PCI with GDMT. While these trials were designed to give us clear answers, they have in fact given us a lot of nuance to unpack. So first, the STITCH trial, which we all know, it was a trial that compared patients with extensive coronary artery disease with a low ejection fraction, subjecting them only to CABG or GDMT alone. So the STITCH initial result was a neutral at 5 years with a p-value of 0.12 for the primary endpoint. However, the subsequent STITCH-S trial was a crucial learning moment for our specialty. It showed that even after 10 years, there was a clear, statistically significant 16% reduction in all-cause mortality with CABG. This is our first major learning, that the effect of revascularization on this population is slow and it is cumulative. A trial with a short follow-up period may completely miss the benefit. So this brings us to the recent REVIVE trial. It was a landmark trial that randomized patients with an ejection fraction of less than 35% with extensive coronary artery disease developed on the BCIS-JS score. They underwent viability testing and either on CMR, DSE, SPECT, or PET. And if PCI feasible lesions were found, they were randomized to either PCI or optimal medical therapy alone, echocardiography at 6 months, 12 months, and routine clinical follow-up at 6, 12, and 24 months plus was performed. While it was a landmark trial, it had a lot of lacunae that limit our ability to apply its finding broadly. So first, the result. The result is that it was a neutral trial, no primary benefit at 3.2 years. The lacunae is that the trial had very sick patients, profoundly ill with a mean ejection fraction of just 26%, and they were already on optimized GDMT regimen. As we have just discussed, the follow-up of such a short follow-up of 3 years may not have been enough to capture the mortality benefit. There is the viability paradox. In this REVIVE trial, this trial was designed for PCI, and they made sure they tested everything. So there was the viability paradox. The trial showed that there was no benefit from PCI, even in patients with proven viability. Now, this challenge is a core tenet of our practice and understanding, but it is important to see the nuance here. While the trial did require a viability cutoff of at least 10% viable myocardium, it did not differentiate between patients with small amount of viable or a large amount of viable tissue. So it is plausible that a patient with only, say, 15% viability may not have enough salvageable myocardium to make a clinical difference in a trial, and by including them and clubbing them with other patients who had far more viable tissue, the potential benefit of revascularization may have been missed. So regardless of the trial's finding, the pathophysiology remains constant. A core belief is that we restore function, but we don't revascularize a scar. We know that revascularization can only function restore function to a myocardium that is hibernating and salvageable. This principle is deeply embedded in our guidelines, both from the ESC as well as the ACC AHA, which give a class 2A recommendation for viability testing in these patients. So this leads us to a new, more thoughtful approach. So can PCI be a complementary therapy to the 4 pillars of GDMT? Instead of viewing revascularization as a competing therapy, we should see it as a complementary one. Our role is to address the ischemic burden that GDMT cannot. GDMT treats the downstream effects of heart failure, while we can address the upstream cause by PCI. By reducing the ischemic burden on the heart, we can improve the LVF, reduce the symptoms, and potentially improve the patient's long-term prognosis. So this leads us to a new strategy in PCI. I believe our success hinges on getting 3 things right: identifying the right patient, identifying the right arteries, and using the right approach. So what do I mean by this? To find the right patient and artery, we use CMR and PET to first find viable myocardium. We need to be judicious and use advanced imaging to identify the patient who may have something to gain from our intervention. The right artery is not just the culprit, but all the arteries that are causing ischemia. As shown in the FAME trial, a strategy of complete revascularization is what yields superior long-term outcomes. This is especially true for patients who have ischemic mitral regurgitation, a specific consequence that can be eliminated or maybe even reversed with a PCI-guided revascularization. So the FAME trial showed that FFR-guided PCI can reduce MACE up to 20% compared to angiography-guided PCI. Finally, we need to have the right approach. This is the heart team approach, a standard of care advocated by all major guidelines. Our role is to collaborate. We should not be acting in isolation or in silo. It's a discussion, it's not a competition. We should be having a collaborative discussion, weighing the options between PCI and CABG. CABG obviously offers more complete and durable solution to extensive disease, while PCI is less invasive, ideal option for patients who are at high risk for surgery. The ultimate decision is a discussion. Finally, when we are in the cath lab, we must use all tools at our disposal. This is exactly where we directly address the critics of the REVIVE trial. It is no longer sufficient to just perform angiography-guided PCI. We now have a seminal trial such as the ULTIMATE trial that showed a significant reduction in MACE with IVUS guidance. Furthermore, large meta-analyses have consistently found that imaging-guided PCI is associated with 33% MACE reduction and 51% reduction in cardiac death. This is the level of procedural excellence that we must all strive to have. Just a few words on CABG versus PCI. This is a crucial discussion, and it is something that we grapple every day in our heart team discussions. The data from trials such as STITCH and REVIVED haven't given us a clear, simple answer as to is CABG better than PCI, but they have helped us understand the specific context where each procedure excels. CABG is often the preferred option for younger, healthier patients with extensive disease, as it offers a durable and a comprehensive surgical solution. On the other hand, PCI is less invasive procedure with lower peri-procedural risk, making it ideal for patients who may be too frail or too high risk for a major surgical procedure. The decision is not a competition again, it's a discussion, and the goal of the heart team is to address this discussion. Finally, there's the hybrid option, wherein, say for example, the patient has a Lima to LED by MICS, and the rest of the vessels are amenable to angioplasty. That option needs further trials and further data to explore as well. So, just to summarize everything, the trials of the recent trials, as well as the STITCH trials, they have not failed us. They have given us a roadmap. Our knowledge and experience will fill the gap. They taught us that a blanket one-size-fits-all approach is never the answer. But they also opened the door for us to create more new and effective paradigms in our treatment. Our role is to be the strategic partner in the care of these complex patients, to use our expertise to identify the right patients, right targets, right arteries, and address them in the best possible way. Thank you.